I think that the multimodality, multi-specialty care here is where everything starts. We have, of course, our Johns Hopkins surgeons and our medical oncologists and our radiation oncologists. But not only that, we really want to navigate this patient population, which is very complex, through our system. The reasons to get those patients here is because of what we have to offer around our medical services, such as nutritional support and dietary support for patients that, despite being young, have the same challenges as older patients and maybe even more complex because they're juggling a bunch of other responsibilities such as childcare and work and care of elderly parents and housework. And I think that patients who are undergoing treatment might make nutrition their least priority, as opposed to the things that they have to do just to get through the day. We also have reproductive services that are extremely important to this particular group of patients. There are surgeries that may alter the ability to have children. There are medical treatments, of course, radiation and chemo, which may prematurely induce menopause or may affect the ability to have children. And so we do have a very good relationship and pathway to our gynecologic services and our obstetrical services for things such as egg banking, ovarian or uterine transposition, hormonal replacement, or just generalized counseling. Same for our male patients. We have services for sexual dysfunction. We have sperm banking, generalized counseling, which are equally as important in a population that may not be so forward with its needs. Part of this is having our navigator tap into these things and create a safe environment for those patients to express those needs. Our geneticists will speak with not only the patient but their families. We have researchers who are looking at advanced germline mutations and specifics of the genetics of each patient. In addition, we have multiple clinical trials for not only our most complex or metastatic patients, but our fairly straightforward patients that may be overlooked for clinical trials or may be excellent sources for information that could be used for other patients. Patients with early onset colorectal cancer can find a variety of clinical trials that look specifically at germline mutations and particularly unique mutations that may ameliorate the need for harmful chemotherapy and allow for immunotherapies that normally wouldn't be considered at other institutions because they're outside of a clinical trial, to be an opportunity for the patient to participate and gain benefit at Johns Hopkins. Also, there are even surgical technologies that are not widely available for patients that have complex disease and metastatic disease, such as hepatic artery infusion pump, portal vein embolization, multi-staged procedures, combined procedures with different subspecialties such as hepatobiliary for liver metastasis, oncology, and colorectal. And I think that even in the most complex cases, there is an individualization of care that might not be available at other institutions that have almost become part of our language here. And we have many patients that come thinking that they're appropriate for one trial, that they're actually appropriate for another trial, or many patients that think that they are patients that are outside the realm of surgical treatability that are actually fairly reasonable candidates for surgery. So I think that this is a center that has trials for the most complicated patients, but there are many trials for straightforward patients that may ameliorate the need for more toxic therapies or more radical therapies. Well, first of all, we want to reiterate our philosophy, which this is not a closed system, it's a partnership with our providers that are outside of Johns Hopkins. Therefore, that patient is not being lost to Johns Hopkins. We are acknowledging that this is a very complex process that has emotional, geographical, financial, and logistical considerations. And so I think a provider should rest assured that the patients are well taken care of here, but that the communication will be very robust, ongoing, and involvement will be very bilateral and almost communal. So our patients engage through our referral line and will be assigned a navigator. So when our patients are engaged in the system, of course, they're going to get deep demographics and engage and be engaged in terms of, the best subspecialty services and the best ancillary offerings that we have. But many people have needs where the care needs to be a partnership with our providers from the outside, and therefore our communication is fairly robust. And we acknowledge that patients that may need therapies that are much more easy and much more logistically feasible to have done close to home with their provider that brought them to us. We acknowledge that is something that we want, and that we can even engage people in clinical trials in tandem with their referring physicians on the outside. So therefore, I think rest assured that our providers will have great communication and will be involved in a true partnership.